Time of 10 o'clock having arrived, the subcommittee will come to order. Chair will recognize himself for an opening statement. Nearly 50 million seniors rely on the Medicare program for their health care. It is important for us to understand Medicare's current benefit structure and look at ways to modernize it to better serve beneficiaries and protect them from catastrophic cost. When it was created in 1965, Medicare's benefit design was modeled on private insurance products available at the time. However, while the private insurance market has undergone dramatic changes in the last half-century, Medicare's traditional benefit structure has remained essentially unchanged. Unlike most private insurance today, which has a single deductible for all medical services, Medicare has separate deductibles for Part A, hospital services, and Part B, physician and outpatient services. While the Part A deductible is rather high, $1,156 in 2012, the Part B deductible is relatively low, $140 in 2012. Medicare fee-for-service also has a complex and sometimes confusing co-payment structure. In addition to the Part A deductible, beneficiaries also pay daily co-payments for stays at hospitals and skilled nursing facilities. Depending on how many hospital stays a senior incurs in a year, he or she may owe more than one hospital deductible for a year. In addition to the Part B deductible, beneficiaries also pay a monthly Part B premium and generally pay 20% of most charges for outpatient and physician services. As Medicare's current benefit structure has no cap on how much out-of-pocket spending a beneficiary can incur, seniors are left open to considerable financial risk and uncertainty. They don't know what they will have to pay when they go in for a procedure or test, and ultimately this uncertainty threatens every senior with the potential of medical bankruptcy. Due to this financial uncertainty and the lack of comprehensive coverage in fee-for-service, almost 90% of beneficiaries purchase or receive supplemental insurance. Everything about our health care system has changed dramatically since the 1960s, as health care has become more and more complex. The models and standards of care, tests, treatments, drugs, and medical breakthroughs that we enjoy today were unknown when Medicare was enacted. In 1965, insurance protected us against hospital costs from conditions that were most likely fatal: heart disease, cancer, and stroke. Today, we use insurance to help manage chronic illnesses and treat diseases, allowing beneficiaries to live for decades and to stay in home and community settings for much longer. The only part of our healthcare system that has not evolved since Medicare's inception is Medicare's fee-for-service benefit design itself. We don't give our seniors 1960s medical care. In many cases, that would be considered malpractice today. So why do we continue to give them a 1960s insurance product? We have an obligation to modernize Medicare and standardize its cost-sharing structure. We should have a single deductible for Parts A and B, and we should streamline benefits so that fewer seniors will have to purchase supplemental coverage with money from their own pocket. We should institute a catastrophic cap on out-of-pocket spending to protect seniors from the threat of medical bankruptcy. And with Medicare's unsustainable financial footing, according to its trustees, Medicare will be insolvent by 2024, and as soon as 2017, we need to expand means testing for higher income beneficiaries in order to protect the most vulnerable seniors. Let's bring Medicare into the 21st century. I'd like to thank MedPAC Chairman Glenn Hackbarth for agreeing to testify today. In recent years, MedPAC has made many recommendations on how to improve the Medicare program, and we are eager to hear about some of them. At this point, recognize the ranking member, Mr. Plone, for 5 minutes for an opening statement.
Thank you, Chairman Pitts, and I'm very pleased that you have decided to consider today's topic. Improving and strengthening Medicare for generations to come is a primary goal of mine. In fact, I've dedicated time to ensuring that seniors have access to affordable health care options and the safety nets that they need to age with dignity and respect. It's no exaggeration to say that Medicare alone is the most successful health care and anti-poverty program ever. And this is why Medicare should be protected and improved, not left vulnerable to cuts in the years to come. The Affordable Care Act begins those improvements. It reduces Medicare spending, extends its solvency, and brings growth in per-patient costs to record lows. In addition, preventative services are now free of charge to beneficiaries, and we finally have laid the groundwork to reward treatment value over volume. I believe more can be done, however. The fact is we are faced with an inevitable reality that our nation's baby boomers are aging into the program at very high rates, higher rates than we've seen in the past. In fact, 11,000 new seniors become eligible for Medicare every day. So I think we need to explore the option of modernizing the Medicare benefit design. Right now, some beneficiaries already pay too much out of pocket, and for years my colleagues and I have explored the need for some type of catastrophic cap for seniors. In addition, the fact that Part A and Part B have such divergent cost-sharing and deductibles might seem arbitrary and confusing. Why shouldn't Medicare be more seamless and simple? But given that the average beneficiary makes only $22,500 annually and already spends disproportionately more on health care than a younger person, makes this very challenging territory. When you change one side of the ledger, it has an impact on the other side, and any reform must be done without significant cost shifts to seniors. But what Republicans want to do when they talk about reform is to cut the structural foundation of Medicare, to turn the whole thing over to insurance companies. And I can tell you right now that that option is simply a non-starter. In addition, any proposals must be carefully examined not by how they might save money, but how they'll benefit beneficiaries, providers, and the system as a whole. We can't restructure the program for the sake of generating savings, whether that's in the name of deficit reduction or to help pay for the SGR fix, because that's bad policy. We must modernize the program because it's good for the very real people that it serves and will serve for generations to come. We have to modernize because we recognize that perhaps it's not designed the most efficient or affordable way, and I stand ready to explore those options, but I will not stand by while others lose sight of the importance of Medicare to our nation's seniors. And I yield back the balance of my time. I don't know if any of my colleagues want time. No? All right, then I will yield back the balance of my time.
Sure, thanks. The gentleman now recognizes the Vice Chairman of the Subcommittee, Dr. Burgess, 5 minutes for a statement.
I thank the Chairman for the recognition. We've heard it several times this morning already. The 10 to 12,000 new beneficiaries added to Medicare every day put pressure on the system and does move it closer towards insolvency. In its current form, Medicare will not be able to meet the promise it has made in a few short years. It's not a surprise. We expect a program designed in 1965 to adapt to the needs and usage patterns of beneficiaries in the 21st century. Medicare's current benefit design needs to be reformed in a way that more adequately reflects the needs and expectations of today's seniors. The first step in moving toward a higher performing Medicare program must be the elimination of the flawed sustainable growth rate formula. Last-minute fixes to the formula certainly have burdened this committee, but it's been devastating to beneficiaries and providers, producing an unpredictable payment environment and has risked beneficiaries' access to care. Last week, the majority, along with the Ways and Means Committee, released the second draft of a proposal to repeal and replace the broken sustainable growth rate formula. The proposal realizes that the key to reforming the system is to enable providers to have flexibility to participate in payment and delivery models that best fit their practice. There will always be areas where providers choose or need to practice in a fee-for-service model. We must also continue to seek out innovative models that can adapt to changes in clinical guidelines and best practices. But at the heart of the issue remains the beneficiary, the patient. As cost pressures increase, we risk the ability to provide access to services for our patients. We must seek reforms that provide patients with greater control of their health care. If we ask the beneficiary to participate in their health care through cost sharing, we are obligated to provide them with a transparent cost information so that they can plan for their future needs. It's hard to plan for what 20% coinsurance means when you don't know what 20% is part of. Enabling patients to be more involved in their care not only allows them greater control of their health care spending, but provides greater protections for patients and moves an outdated program into the future. We've neglected these problems for far too long. We know the structural and fiscal problems in the healthcare system. The only question now is how long will Americans tolerate Congress staring at these problems without actually fixing them for future generations? Very grateful to see Mr. Hackbarth back with us this morning. He's been before our committee several times. MedPAC has recommended a range of different policies over the years to reform Medicare's benefit structure. I certainly look forward to hearing more of these ideas in Mr. Hackbarth's testimony, and I would now like to yield to the gentleman from Georgia, Dr. Gingrey.
Mr. Chairman, I thank the Vice Chairman for yielding to me. As a physician for over 30 years, it was my job to engage with patients and offer them a straight answer, no matter the seriousness of the prognosis. And I think at this point it's incredibly important for Congress to do the same thing, to engage seniors on the urgency of Medicare's fiscal situation and work to explain how changes to the current Medicare benefit can decrease personal risk and increase the solvency of the program. I don't think that anyone here would disagree that the Medicare program of today is in trouble. The hospital trust fund is set to run out, somewhere between 2017, 2024, whoever you believe, but clearly it's coming. What will happen once this point occurs is anybody's guess. Though looming fiscal disaster must certainly be addressed before the fund is exhausted, least we leave beneficiaries with unacceptable cost or lack of access to care, or both. Mr. Chairman, we must look for ways to improve the Medicare benefit, not only for our current seniors, but to ensure those benefits are there for future generations. We have a system that was created in the 1960s, as Dr. Burgess was just mentioning. Very few adjustments since then. The way we practice medicine today has changed, and it's time for the way we pay for medicine to reflect that. And I thank you, Mr. Chairman, for calling this hearing. I look forward, as I know my colleagues do, to hearing from Mr. Hackbarth. He's been with us, as has been said, a number of times, and his suggestions for restructuring the benefits and incentives to improve Medicare for this country's beneficiaries is welcome. And so I thank you, Dr. Burgess, and I'll yield back.
Chair, thank you, gentlemen. Now recognize the ranking member of the full committee, Mr. Waxman, 5 minutes for opening statement.
Thank you, Mr. Chairman. For more than 4 decades, Medicare has been a critical program for ensuring the health and the financial well-being for seniors and disabled people. I appreciate the opportunity to talk about ways we can continue to improve the program by broadening the protections for beneficiaries and improving the value of the program for both beneficiaries and taxpayers. And I welcome our witness from MedPAC, Mr. Hackbarth. I appreciate your coming back to our committee. The recognition by the MedPAC that we should improve beneficiary benefits by putting a limit on out-of-pocket catastrophic spending, rationalizing deductibles, making co-insurance and co-payments more predictable makes sense, but with any policy, the devil's in the details. The median income for Medicare beneficiaries is only $22,500 a year. A lot of people think that the elderly are the wealthiest, and there are wealthy elderly, but the median income is $22,500. Medicare beneficiaries already pay more out of pocket for health care than individuals under 65. So any proposal to redesign Medicare that leaves beneficiaries holding the bag is not one that I can endorse. That's why I'm glad to see that a key element of MedPAC's proposal is that it's, quote, beneficiary liability neutral. That is, on average, beneficiary out-of-pocket payments should not increase, and at the same time we need to keep in mind that there will inevitably be winners and losers within the Medicare population. There are other elements of MedPAC's redesign option that I believe need more careful scrutiny. MedPAC also recommends adding a charge for supplemental insurance policies, whether provided by employers or purchased by individuals, to offset the financial impact to Medicare of first dollar coverage. I think there are two important points to be made here. One, that these are not separate proposals. The proposal to reform supplemental coverage is linked and not severable from improving Medicare beneficiary benefits. That is important because I'd hate to see some of my colleagues who are more concerned with cutting costs than securing benefits try to do one without the other. We also need to carefully assess the impact this could have on the near poor who do not qualify for Medicare extra help for their out-of-pocket costs and may not have the means to afford any additional costs. My second point has to do with the unintended consequences that eliminating first dollar coverage could have on necessary utilization. The problem is that the relationship between cost sharing and service utilization is not the same in low-income and elderly populations, especially sick elderly populations, as it is in younger, healthier populations. The Medicare population is older, poorer, with 50% of beneficiaries at or below 200% of the federal poverty level, and sicker, with 40% having 3 or more chronic conditions than the general population. As a result, if we make supplemental insurance less affordable or reduce the level of coverage, Medicare beneficiaries are at greater risk of deferring not only unnecessary care, but necessary care, negatively impacting their health. As we think about opportunities to improve the benefit package in Medicare, we must add protections for beneficiaries and at the same time be careful not to generate both predictable and unintended consequences. We must continue to protect our most vulnerable citizens who are seniors. Finally, we must make sure that we're not using program redesign as a pretext for reducing spending by shifting costs onto those beneficiaries. Thank you, Mr. Chairman. I yield back the time.
Chair, thanks to gentlemen. That concludes the opening statements to the members. We have one witness today, and on our panel today we have Mr. Glenn Hackbarth, Chairman of the Medicare Payment Advisory Commission. Thank you for coming. You will have 5 minutes to summarize your testimony, and your full written testimony will be placed in the record. At this point, you're recognized for 5 minutes.
Okay, thank you, Chairman Pitts and Ranking Member Pallone and Vice Chairman Burgess and Ranking Member Waxman. I appreciate the opportunity to talk about MedPAC's recommendations on redesigning the Medicare benefit package. In our view, the current Medicare benefit package is both inadequate and confusing. It's inadequate in the sense that it lacks catastrophic coverage, that is, a limit on the maximum out-of-pocket costs that can be incurred by a patient. It's confusing with its bifurcated Part A and B structure and a complex system of patient cost sharing, a mixture of co-payments and percentage co-insurance. In our view, the status quo, the current benefit package, is not good for Medicare beneficiaries nor for taxpayers. Because of the inadequate and confusing nature of the Medicare benefit package, many beneficiaries are induced to buy supplemental coverage, often at a very high price. Taxpayers, in turn, must pay for the increased costs resulting from supplemental coverage that often covers even the first dollar of out-of-pocket expense. In our view, the principal winners from the status quo are the insurance companies that sell supplemental coverage. It's a lose-lose proposition for Medicare beneficiaries and for taxpayers. With these inadequacies in mind, MedPAC has recommended redesigning the Medicare benefit package consistent with 5 principles. First, there should be no increase in the average Medicare beneficiary liability for out-of-pocket costs. In other words, the benefit package should not be reduced in its actuarial value. We don't believe that Medicare currently is too rich a benefit package. If anything, it is too lean given the population served. Second, we believe that a redesigned Medicare benefit package should include an out-of-pocket limit, that is catastrophic coverage. Third, we believe that wherever possible, the Medicare benefit package should be simplified. For example, by substituting fixed dollar co-pays for percentage coinsurance. Our research with beneficiaries shows that fixed dollar co-pays are much more readily understood and provide some comfort to beneficiaries about what their costs will be for particular services. Fourth, we believe that Congress should give the Secretary of HHS the authority to modify the Medicare benefit package consistent with the principles of value-based insurance design. That means that the Secretary should have the authority to reduce out-of-pocket payments for beneficiaries for services that are established by scientific evidence to be of high value to patients. Conversely, the Secretary should be able to increase co-payments for services that evidence shows are of low value to patients. Finally, we recommend that Congress institute a charge on supplemental coverage. The purpose of the charge would be to assure that beneficiaries who elect to buy supplemental coverage share in at least a portion of the additional costs that private decision results in for the taxpayers in the Medicare program. The premium that a beneficiary pays for supplemental coverage only covers a fraction of the additional costs that the program incurs as a result of supplemental coverage. Let me conclude with 3 points that I think bear particular emphasis. One is that patient cost sharing is an imperfect method of controlling costs, albeit a necessary one in the context of a free choice of provider, largely fee-for-service insurance program. We don't believe that patient cost sharing should be the only or even the principal method of trying to control costs. Indeed, most of MedPAC's work focuses on changing how we pay providers, providing better incentives for high-value care. The second point I'd like to emphasize is that by giving the Secretary the authority to institute value-based insurance design, we can improve the targeting of cost sharing, making it less likely that cost sharing will have an adverse effect on quality and outcomes. Finally, I'd like to emphasize that we would not prohibit Medicare beneficiaries from buying supplemental coverage, even first dollar coverage, if they so desire. We only think that Medicare beneficiaries should face some of the additional costs that decision imposes on the Medicare program and the taxpayers. I should also emphasize that the supplemental charge we would envision only as part of an overall package. All of these recommendations we see as an integrated package, not isolated recommendations. With that, Mr. Chairman, I welcome your questions.
For that purpose. Mr. Hackbarth, many experts have noted that traditional Medicare is an outdated form of health insurance coverage and needs to be modernized. In 1999, AARP's Public Policy Institute published a paper entitled The Effects of Merging Part A and B of Medicare. They said, quote, Medicare's two-part system continues to mirror the structure of private insurance at the time of Medicare's inception in 1965, a structure that often included separate insurance for hospital and physician care, end quote. Do you agree with the AARP that Medicare's separate hospital and physician benefits closely resembled the type of insurance available to consumers in the 1960s?
Yes.
Medicare Advantage, more modern type of coverage signed into law in the late 1990s, is also modeled closely after the types of insurance available to consumers at the time. Do Medicare Advantage plans use separate insurance for hospital and physician care?
No, not to my knowledge, sir.
Medicare drug plans are even more modern, having been passed into law by Congress in 2003. Do Medicare drug plans have catastrophic coverage caps?
Yes.
Is the traditional Medicare benefit the only type of comprehensive coverage in Medicare that does not have a catastrophic coverage cap?
Yes.
And for the record, is it MedPAC's position that Congress should update traditional Medicare fee-for-service to include a catastrophic coverage cap among other reforms, because these reforms would benefit seniors.
Yes.
Thank you. Nearly 50 years have passed, and Medicare's model has become outdated. Seniors deserve a modern product that meets their needs and helps them control cost. I think it's time for Congress to strengthen and save Medicare, making sure that current beneficiaries get what they need, and also that future retirees can count on the program being there for them one day. Now, AARP's Public Policy Institute paper also states that, quote, a third criticism of two systems of financing for Part A and Part B has hindered management of the original fee-for-service Medicare. Integrating all of Medicare's funding sources into one pool of money would enhance management of health resources and improve accountability for health spending in FFS Medicare. Can you tell us your thoughts on what impact this antiquated two-tiered financing system within traditional Medicare has on CMS's ability to manage health spending appropriately, and do you believe it is possible that the antiquated manner in which traditional Medicare fee-for-service is financed might be contributing to the amount of waste, fraud, and abuse lost each year?
So you're asking about the financing, separate financing of A and B, with payroll tax used to finance Part A and premiums and general revenues for Part B? That's we've not specifically looked, Chairman Pitts, at the financing mechanisms and what the implications would be for fraud and abuse. We've focused on the benefit design and payment methods for providers primarily.
Now, you state in your testimony, one key purpose of insurance is to reduce the financial risk posed by catastrophic medical expenses. To avoid such risk, individuals should be willing to pay a higher premium than the average cost of care they might face. Can you expand on that idea for us?
Well, probably the single most important feature of any insurance program is a limit on the maximum out-of-pocket costs that a patient can incur. Now, the nature of medical expense is that most of it is unpredictable. So a given beneficiary in any given year might pay a premium but not use, the insurance may not use the catastrophic costs. Yet you pay the premium against the risk that it might be your year to have a very serious illness and incur high bills. That's the nature of insurance. A lot of people pay an amount, don't use the full amount. They pay premiums higher than their actual incurred expenses, so that when their day comes and unfortunately they suffer a severe illness, the protection is there for them.
All right, my time's expired. Thank you. Chair recognizes the ranking member of the subcommittee, Mr. Pallone, for 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Hackworth, I'm just following up on, to some extent, on what the chairman just said. While MedPAC included a unified deductible, combining the Part A and B deductible into one unified deductible, in your illustrative scenario, you did not actually recommend a unified deductible. So why is that? Can you talk about the pros and cons of a unified deductible?
Yeah. You're correct, Mr. Pallone. We did not specifically recommend a unified deductible. We felt that the precise structure of the cost sharing is a decision that ought to be delegated to the Secretary in keeping with the principles of value-based insurance design. The argument for combined deductible is that it's simpler and that it's more in keeping with the basic principles of insurance, where you want to provide the most protection to patients that have the highest cost. The current structure, as you well know, has a relatively low deductible on Part B and a significantly higher.
What's the downside then? What's the downside? Why?
The downside of moving to a combined deductible is the impact on beneficiaries who use only Part B services in any given year. They would have a higher deductible than the current $147 that they have in Part B deductible.
All right. Let me ask about SGR reform. I know you can. I appreciate the fact that MedPAC continues to lead and support SGR reform, and you know I share the sentiment of the commissioners that it's past time to take action. But I also appreciate the recognition that we need to move delivery systems and payment systems reform toward more value-based systems that were included in the ACA, like the medical homes and accountable care organizations. But with regard to SGR reform, is my understanding correct that MedPAC is not recommending that costs be shifted to beneficiaries?
Well, we have recommended in benefit design, as I said in my opening comment, that the average liability for beneficiaries not be increased.
Okay, so just to clarify further, MedPAC has not recommended that an SGR fix be offset within Medicare. Is that accurate?
We did not recommend that. We believe that's Congress's decision to make. What we've tried to do is offer options for offsetting the cost within Medicare if Congress elects to fully offset SGR.
So you're not recommending that
we have
be
not
offset within Medicare?
Right.
Okay. Now, I'm concerned that some people are eyeing this idea of Medicare benefit redesign as a way to simply get budgetary savings by shifting more costs onto the backs of beneficiaries. However, in looking at your redesign recommendations, I noticed that you recommend beneficiary liability remains neutral, that overall beneficiary cost sharing levels stay the same in aggregate. So even though some beneficiaries will see their costs go up and some will see their costs go down, the overall out-of-pocket costs for the average beneficiary will stay the same. So am I reading that correctly, that MedPAC doesn't envision or propose any savings from benefit redesign itself?
From the redesign itself, no, sir.
So in your proposal, isn't it true that the savings come from the tax on first dollar supplemental coverage?
That's correct.
And was keeping beneficiary liability neutral an important principle for the Commission? Did you want to comment on that?
Yes, it's a very important principle from our perspective. As I said in my opening comment, we don't think the current benefit package is too rich. If anything, it's too lean. Our principal concerns about it are its inappropriate structure. It's not well designed for the needs of the Medicare population, and we think it should be restructured.
Can you share with us why not cost shifting to beneficiaries was felt to be so important? Do you want to comment on that as well? I know you have to some extent, but...
Yeah. Well, as I say, we think for the population served, which is an older, obviously somewhat higher risk population, this is not a rich benefit package compared to what employment-based coverage offers, for example. And so rather than try to achieve savings by cutting benefits, we thought it was better to redesign them. Now, it's possible that if we have a simpler design and one that includes catastrophic coverage, that some beneficiaries will choose to forego supplemental insurance over time. And if that happens, we would expect that might result in lower utilization because there would be more cost sharing at the point of service. But it would be the beneficiary's choice to do that.
All right. Thank you so much. Thank you, Mr. Chairman.
Sure. Thanks, gentlemen. And now recognize the Vice Chairman of the subcommittee, Dr. Burgess. 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Hackbarth, let me just ask you, in a Medicare Advantage system, would a patient buy supplemental insurance for Medicare Advantage?
Typically, they would not. Medicare Advantage is offering a different set of trade-offs. So typically, patients have lower cost sharing at the point of service in exchange for agreeing to perhaps network limitations. They're steered to particular providers by the insurer, or their benefits are subject to utilization management, prior authorization or other management controls. So that's the trade-off. Lower cost sharing, more management.
I guess I'm having a hard time understanding. It seems like if someone buys a supplemental insurance policy as they enter into Medicare, they're doing the responsible thing by putting some of their own dollars into their future health care by covering against what would be excessive out-of-pocket costs if they get sick. So they are, it looks to me from a physician standpoint, they're doing the prudent thing. Now, I honestly can't tell you that I ever got a reimbursement check from a Medigap policy. So, I mean, I don't know. Maybe those dollars never go where they're supposed to. But it looks like the patient is doing the prudent thing with doing that. But you seem to articulate a different opinion.
Well, our view is not for or against the purchase of supplemental insurance. We believe that beneficiaries should have the option of buying supplemental insurance, even first dollar supplemental coverage, if that's what they wish. We do think that they ought to see more of the costs that result from that private decision. The premium that they pay for supplemental insurance reflects only a fraction of the additional costs that result from that decision.
But isn't ultimately that's why someone buys insurance, correct? So that they're not hit with the entire cost of whatever the event might be that they're insured against.
Yeah, but even against insuring against this event, they are underpaying for that cost. You know, the right price for insurance should reflect the full cost of the purchasing decision. In the case of supplemental insurance, it does not. Well, it reflects only a fraction of the cost.
Let me interrupt you because my time's going to run out. But I won't say whose fault is that, but I mean, why penalize the poor person who's trying to do the right thing and buying supplemental coverage with their own hard-earned dollars? It doesn't make sense to me to penalize or tax that person additionally. If you want them to be bringing some of their own dollars to the system to keep the system solvent.
But we only want for beneficiaries to see more of the cost of the decision that they make. That's it.
I don't disagree with you. I mean, I think we have anesthetized people as to what healthcare really costs, and that's the argument for the entire health savings account, third-party payment mechanism that is ubiquitous in healthcare. And perhaps we can talk about that at another time. When President Obama was doing his charm offensive up here a couple of weeks ago and met with House Republicans down in the basement, I got to tell you, several years ago in one of the SGR fixes that I've introduced since coming to Congress, and there have been several, but one of them actually did away with Part A and Part B and melded them together. I got a lot of pushback when I introduced that. So I was surprised to hear the president say one of the throwaway lines in answer to a question was we could combine Part A and Part B. I guess now, as I further understand that was combining the deductibles. But is that a rational approach to dealing with some of these difficulties?
Well, again, we in our recommendation did not specifically recommend a combined deductible. We did recommend catastrophic coverage that covers both A and B. On the issue of the combined deductible, we think that actually that's a decision that ought to be part of an overall redesign of the cost sharing in keeping with the principles of value-based insurance design.
Well, you do, of course, end up with some people who don't participate in Part B. They have their Part A coverage because of the payroll deduction that they've contributed throughout their working lives. So it's not a completely universal population. Let me just ask you another question. A cardiologist in this country 4 or 5 years ago just underwent a practice upheaval, and largely because of the administrative pricing brought to them by Medicare. In other words, to do an echo or a treadmill test in the office suddenly was undervalued, and it was overvalued, or in my opinion, overvalued to do that in the hospital. And as a consequence, you've seen cardiologists leave their individual practices and be hired by hospitals and insurance companies, so that the private practice, solo practice of cardiology, small group practice of cardiology has gone away. And yet, the technology is changing such that, well, I don't know, NBC had a special on the other night where Dr. Schneiderman interviewed Dr. Topol out of San Diego. And with a smartphone and a couple of little adapters, he was able to do an EKG, an echocardiogram, and a continuous transcutaneous glucose monitoring. He was providing a lot of care at a very low cost in an office setting, but we've kind of actually priced him out of business, have we not, with our administrative pricing in Medicare?
Well, as you know, Dr. Burgess, one of the issues that we're working on currently is synchronizing the payment systems between the hospital outpatient departments and physician offices. So historically, there have been dramatically different prices paid for the same service based on the location, physician office versus outpatient department. That is the problem. And that is skewing incentives and we think contributing to the migration of physician practices, including cardiology practices from outpatient, privately owned offices into hospital outpatient departments.
But I think Medicare was the cause of that rather than the effect, your reimbursement. But I realize my time is up, Mr. Chairman. I'll yield back.
Chair, thanks, gentlemen. Now recognize the ranking member emeritus, Mr. Dingell, for 5 minutes for questions.
Mr. Chairman, thank you for holding this hearing. Thank you for the recognition. And to our witness, thank you. You've given us very excellent testimony this morning. As you will recall, it's my practice to ask for yes or no answers. I invite you, if you can, to give us such supplemental information as you might deem to be appropriate.
Okay, I'll try, Mr.
We very much appreciate that. My old friend Hubert Humphrey once said the moral test of a government is how the government treats those who are in the dawn of life, in the twilight of life, and in the shadows of life. Medicare helps our country meet that moral test by ensuring that our sick and elderly have access to care in the time of need. My old dad was one of the architects of Medicare, and it has endured as one of the great and significant pieces of legislation. Now, Mr. Hackbarth, I want to again express my appreciation for your fine testimony this morning. You note in your testimony that the cost-sharing structure of fee-for-service benefit has remained unchanged since 1965. Is that correct?
Literally, no, it is not. There have been some changes.
Have there been any really significant changes?
No.
There have. All right. Would you submit that for the record? The current fee-for-service benefit has significant cost-sharing requirements for beneficiaries. Is that correct?
Yes.
Almost 90% of fee-for-service beneficiaries have supplemental coverage. Is that correct?
Yes.
Do you agree that the beneficiaries may choose to have supplemental coverage due to cost-sharing requirements in the current fee-for-service system?
Yes.
MedPAC has proposed an additional charge on supplemental coverage on Medigap and employer-sponsored retiree plans. Is that correct?
Yes.
And you have proposed this charge because the Commission believes that supplemental coverage leads to increased utilization and spending. Is that correct?
Yes.
And it also would be fair to say, as you have observed earlier, that it is necessary for us to recoup some of the additional burdens that imposes on the Medicare trust funds. Is that right?
Yes.
Do you think that an appropriate charge would be, what do you think would be an appropriate charge on supplemental coverage?
Can I do a short answer?
That's not a yes or no answer. So
Okay, good. We modeled 20%, a 20% charge, but we did not recommend a specific number.
I'd appreciate if you'd make some additional submissions to us on that point, because it's a very important question. Who would be required to pay this charge? Now, we have some potentials here. Would it be individual policies?
We would impose it on the insurance company. It would, and then it could be passed through in the premium, depending on how the market sorts it out.
Thank you. Would it be on employer-sponsored retiree plans?
Yes.
And would it be applied only to new beneficiaries?
No.
Would it be applied to everybody?
Yes.
I note the administration seems to be saying that these charges will be applied only to new beneficiaries after 2017?
Yes.
It is my understanding that this administration, I've already asked that question. Do you agree that the supplemental charge would cause Medicare beneficiaries to face additional cost sharing? Now, you've had some comments on that. Would you want to amplify on that?
Yeah, could you just repeat it again?
Okay, do you agree that the supplemental charge would cause Medicare beneficiaries to face additional cost sharing?
Well, certainly the supplemental charge itself would be an additional cost. How beneficiaries would respond to that is difficult to predict. What we think would happen is the current beneficiaries may not change their choice of policies as significantly as new beneficiaries coming into the program over time.
Now, you've indicated that you don't intend to increase the burden on the population of beneficiaries generally. Am I correct in that?
In our benefit redesign?
Yes.
No. We want to hold that constant.
Now, do you agree that the supplemental charge could cause some beneficiaries to drop or reduce their supplemental coverage due to the additional charge?
We think that it may cause some beneficiaries to change their choices. As you well know, there are a wide range of different supplemental plans. Some have front-end cost sharing, some do not. So there might be a move from first dollar supplemental coverage to policies that have some cost sharing at the point of service.
Now, I happen to think that a charge on supplemental coverage could result in Medicare beneficiaries not seeking out the services and care they need or delaying treatment or care until it's too late. I think that's a potential risk. But first, is it a risk? And second, what do we do about it?
Yeah. It is a risk, and this is why we think it's very important to give the Secretary the authority to adjust cost sharing based on the principles of value-based insurance design. In other words, reduce cost sharing for services of proven high value to patients and perhaps increase cost sharing for low value services.
So you're suggesting the Secretary should have authority to adjust those charges, but that should be subject again to requirements in law that would say he can't necessarily change the overall structure to create a disadvantage to the population. Is that right?
Exactly.
Mr. Chairman, I've gone over time. Mr. Hackworth.
Chair, thanks, gentlemen. Now recognize gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you, Mr. Chairman. I was intrigued with your testimony in regard to the secretarial authority to alter or eliminate cost sharing based on the evidence of the value of services. Mm-hmm. And I was wondering if you could expand on that, because one of my concerns would be is that I understand if something has a high benefit, lowering that copay, but you could theoretically raise the copay so high that people couldn't afford it, even if they really wanted to do that. And I'm concerned that for a particular patient and a particular doctor, they may make a decision that perhaps universally might not have great benefit, but could to that patient. I was wondering if you could expand on that. And
yeah,
my thought was maybe put caps on the high end.
Yeah. So as you know, a number of private insurers and employers have been moving towards the idea of value-based insurance design. Typically, the focus has been on reducing patient copays for services of high proven value. An example would be having low copays for services provided to diabetics or patients with multiple chronic illnesses to make sure that they get the care they need to prevent worsening of their health and potentially higher bills as a result of that. There has been less done in terms of increasing copays for low value services, probably for the obvious reason that that's more controversial than reductions are. So I would anticipate that at least initially most of what the Secretary might do with this authority is lower copays. That said, there are services that sometimes can be quite expensive but are of low value to patients. And rather than prohibit access to those services and say, oh, you're a Medicare beneficiary, you can't have that service at all, the idea would be to say, okay, you can have it, but you're going to pay a bit more of the cost of that service if it's a proven low-value service.
And I don't come from a medical background. Can you give me an example of one of those that across the country would have a low benefit and might need to have the fee raised?
Since I'm not a physician either, I would be reluctant to do that. What I would say is that this should be done thoughtfully, and it would be done as part of a notice and comment rulemaking process. So the Secretary would have to publish the evidence to support this low-value assessment, and all relevant parties would have the opportunity to contest that evidence and respond to it. And I think that's the way it ought to be decided by experts, not by people like me.
As a representative of the public, and while I generally think experts do a pretty good job, sometimes I have big disagreements with them, and I would just have to say that while I kind of like the idea, Mr. Chairman, I would want to see if we were to authorize the Secretary to do that, I would want to see some kind of a cap on the top of the as a top number, so that you wouldn't be in a position where suddenly a procedure is completely voided because the cost is just so horrendous that nobody can justify it except for the extremely rich. So I do appreciate that. With that, Mr. Chairman, I will yield back my time.
Chair, thanks, gentlemen. Now recognize the gentleman from Utah, Mr. Matheson. 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Mr. Hackbarth, for being here today. It seems to me that one of the outcomes of your suggested change in this benefit design has something to do with overutilization and trying to address that issue in terms of having the individual patient have a little more of a consumer orientation. Mm-hmm. Is that a fair assumption?
Yeah, that's part of it, Mr. Matheson, but the most important part from our perspective is to improve the benefit package for beneficiaries, including catastrophic coverage.
I wanted to talk a little bit about a particular component of overutilization. I may be getting a little off the specific benefit design topic of this hearing, but I know in your MedPAC March report you identified some specific geographic areas where there is a strong reason to believe that certain inappropriate billing practices are at play in the home health care industry. And I've seen some data that's pretty phenomenal in my mind. I compare my state to Miami-Dade County. I got 190,000 Medicare beneficiaries in Utah. There are about that many in Miami-Dade County. However, there are 700 home health care providers in Miami-Dade County and about 100 in Utah. Home health services in Utah cost Medicare a lot less than the services performed in Miami-Dade. The average cost per enrollee in Utah is $560. The average cost in Miami-Dade County per enrollee is over 6 times that amount at $3,500. Strikes me that the vast majority of providers in the home health care industry in Utah are doing the right thing. And it strikes me something's going on in Miami-Dade County that doesn't pass the smell test. And it seems to me that it's an important issue for us to look at in how we try to seek out these pockets of geographic areas where there's this huge overutilization going on, and instead of doing a policy that may affect all providers, and those, including those that are doing the right thing, that we target those who aren't. So in the instance of home health care, I was wondering if would it be better for Medicare in terms of saving money and decreasing overutilization to scrutinize the issuance of new provider numbers or to look at reasonable limits on episodes of care in these high utilization areas like Miami-Dade County?
Yeah, there are two types of problems in home health care as we see it. But before I focus on the problems, let me emphasize that we think that home health care, good home health care, is an essential part of good quality care for Medicare beneficiaries.
Yeah, and I agree.
So in no sense are we against home health care. But there is, as you say, evidence that in some parts of the country we have extraordinary levels of use, an extraordinary number of home health agencies, and we think indications of fraud and abuse of the benefit. And we have made recommendations for targeted efforts to deal with those problems, including limits on the number of new agencies in those problem areas. So we think that's an important thing to do. Having said that, though, across the country, we believe, even in the low-use states, we are paying too much for each episode of home health care. So even where there isn't that fraud and abuse, we believe the rates are too high relative to the costs incurred.
In terms of this situation where you've got some certain geographic locations where there appears to be extremely high overutilization compared to a peer comparison elsewhere, is it reasonable to assume that this situation is occurring in other aspects of Medicare services in this country outside of home health care?
Well, Quite possibly, yes. Another area where we see extreme variation is durable medical equipment. Post-acute care in general, which includes home health care and DME, account for a significant portion of the geographic variation that is the focus of so much attention in Medicare.
We feel like in our state we practice medicine in a way if the rest of the country did it, we'd be saving a lot of money with outcomes just as good. And so I think this is something, Mr. Chairman, I know it's a little outside of this benefit structure of this hearing today, but this issue of discrepancies in utilization across different geographic areas is something that I think is worthwhile for us all to take a look at and provide some real opportunity for some savings. And with that, I'll yield back.
Chair thanks the gentleman. Now recognize the gentleman from Kentucky, Mr. Guthrie, 5 minutes for questions.
Thank you, Mr. Chairman. And I'd like to follow up a little bit on what my friend from Utah was talking about, because you have talked about, and you mentioned again, the high margins that you in the home health. And I know home health, in my understanding, has been cut, 21% since 2010. And for publicly traded home health, that's the information I was able to get. Before tax margins in 2009 were 13.4%. In 2012, 3.9% of I think there's 4 publicly traded. And after tax margin in 2012 was 2.5%. So, it seems like if you had more in Miami, you'd get better competition, and you'd have so it's kind of counterintuitive how that works, how that's happening. So there is issues going there. And I guess my question is, you have a report that had the margins. What was your methodology in that report?
We use Medicare cost reports. So in contrast to the publicly traded companies, what we are looking at is Medicare-specific profit margins, whereas for a publicly traded company, you would be getting a combination of Medicare margins and margins on private insurance as well.
Okay.
So it's an apples to oranges comparison.
Okay, well, thanks for that. On the supplementals, so you were saying the number you've suggested, I know you didn't recommend, is 20%, or you looked at as 20% should be actually added to the premium. You said charge to the insurer, but the premium should be 20% higher to reflect the true cost of buying, true cost to the taxpayer for buying supplemental.
Yeah, so the example that we modeled was a 20% charge that would be imposed on the insurance. How that would affect the premiums would depend on, market competition in different markets. In some cases, it might be all passed on. In other cases, it might not be.
So the additional cost that you're trying to capture is what the supplemental policy does in terms of utilization?
Increased utilization. So our analysis shows that beneficiaries that have supplemental coverage use about 1/3 more services after adjusting for differences in age and risk, et cetera.
This was for risk, because the more likely you are to use the system, the more the sicker you are, the more likely you are to buy a supplemental policy.
But in our analysis, we adjust for risk.
Adjust for that. Well, thanks. And yield back my time.
Chair thanks the gentleman. Now recognize the gentleman from Texas, Mr. Green, 5 minutes.
Thank you, Mr. Chairman. Ms. Hackberg, thank you for appearing today, and again, thank you for a lot of the information we've worked on for many years. MedPAC's proposal for benefit redesign is careful to point out that aggregate beneficiary cost sharing will be kept the same. You point out in your testimony that the reason for this is the Commissioner's judgment that traditional Medicare's benefit structure is not too rich, especially for the population covered. One of your goals is to protect the beneficiaries against high out-of-pocket spending while not reducing the actual value of the benefit package. Can you explain what you mean by the benefit package not being too rich?
Right. A way to judge the richness of a benefit package is what percentage of a patient's costs are paid through insurance as opposed to out-of-pocket. Using that as the standard, we don't think that the percentage paid by Medicare of total beneficiary costs is too high. In fact, if anything, it may be too low. So we accept it as a starting point that we ought not be cutting the amount paid by Medicare. That would put too much of a burden on beneficiaries. but we felt like there were a lot of things we could do to make the package better, including providing catastrophic coverage and making it simpler. We thought that those changes, in turn, might cause some beneficiaries to say, you know, I don't need to pay, you know, $175 or $200 a month for supplemental insurance, which is a big burden on many beneficiaries as well.
Frankly, in our area, some of the 175 or 200 a month is pretty small, and I've seen some quotes for that. Right. Now, switching gears, a lot of attention has been given to supplemental insurance plans, like you just mentioned, in Medicare, particularly those provided by employers or Medigap plans purchased by individuals. Is there a lot of there's a lot of concern about Medicare patients not having enough skin in the game, so to speak, because of their supplemental policies often pick up deductibles, co-pays, and co-insurance. As I understand, your proposal charging or paying a premium for this first dollar supplemental insurance is intended to offset the cost of some of the other benefit design changes?
Well, the overall package that we modeled, including the catastrophic coverage and the new structure of co-pays, would have resulted in a modest increase in Medicare expenditures, about 1%. And so in our package, we combined that modest increase with this 20% charge on supplemental insurance. And the net result of those two things would be a modest reduction in total Medicare expenditures of about 0.5%.
Okay. I understand that correctly. Is it true that cost sharing reduces both necessary and unnecessary care?
Yes, that's what the evidence shows, and that's why we think that giving the Secretary the authority to do smarter cost sharing, not just across the board, but targeted based on value, is so important.
Well, and I understand that we want patients more active in their decisions on their care, but that may work for some of us or younger elderly patients, but a lot of our older patients who are sicker, and they just may take a more passive in their care and their decision making. But and Mr. Chairman, I remember I was a state legislator in the 80s, and we had a senator from Texas, Lloyd Benson, who worked on trying to do catastrophic and reform Medicare, and somehow the seniors got Congress's attention. And I remember talking to Senator Benson at that time, and he said we just went too far for what our seniors would accept, and it was a revolution by those under Medicare almost in the late 80s.
In fact, I worked in what was then HCFA, the Healthcare Financing Administration, during that period, so I remember it well.
Yeah, and I understand, Mr. Chairman, there's some good parts of this, but we need to look at it because I would like, a lot of seniors would like not to have
Yeah, and unfortunately, I think the current structure without catastrophic coverage almost compels seniors to pay that high monthly premium for supplemental insurance because the Medicare package does not offer them the most basic feature of a good insurance plan, an out-of-pocket limit.
Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentlelady from North Carolina, Ms. Elmers, 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Hackbarth, I have a document here which is basically a list of bipartisan quotes from both conservative and progressive authors relevant to the proposals, many of which you are proposing today. Mm-hmm. And I will just say that drawing from it, President Obama's National Commission on Fiscal Responsibility and Reform, released in 2010, quoted, this is a quote taken from that bit of information. Currently, Medicare beneficiaries must navigate a hodgepodge of premiums, deductibles, and copays that offer neither spending predictability nor protection from catastrophic financial risk. The ability of Medicare cost sharing to control costs either under current law or as proposed above is limited. Do you believe, and I think you can probably just give a yes or no answer to this, do you believe that MedPAC's reforms, as they encourage more predictable out-of-pocket costs and limit on catastrophic costs, may allow seniors to better plan for balance in their future health care and financial needs?
Yes.
Thank you. In 1995, Henry Aaron of the Brookings Institute and Robert Reicher of the Urban Institute had this to say about combining Medicare Part A and Part B. Whatever and this is a quote, whatever rationale may once have existed for the distinction between services in Part A and Part B medical technology, the development of new reforms and service delivery and new payment structures have rendered it obsolete. I raise this point because we think it is important, and as part of the conversation today, that we all understand that Medicare traditional benefits are obviously outdated and cause unnecessary harm for our seniors as a result. There again, in your opinion, yes or no, do you believe the concept of combining Part A and Part B is a good Medicare idea?
Yes. As I said earlier, our recommendation is for a combined A and B catastrophic limit.
Catastrophic, okay.
We have not specifically recommended an A and B combined deductible.
And do you believe that the concept of this can be characterized as a Republican idea?
Well, this package that I've described today was unanimously recommended by the members of MedPAC, 17 members of various political persuasions.
So basically you would have to say no then?
We are a nonpartisan agency, and we really try to live up to that billing.
To be bipartisan, okay. The AARP's Public Policy Institute had this to say about the traditional Medicare benefits designed in 1999, quote, Medicare, widely considered to have been successful in improving across access to care and lessening the financial burdens of health care for older Americans, is also reviewed as a program in need of a more updated management structure. The two-part system that drives many of its payments and revenue policies almost certainly would not be adopted if the program were being designed today. The current design reflects some factors that, while relevant when Medicare was initiated in 1965, are not now pertinent. In your opinion, do you believe that the current design of Medicare traditional benefits reflects some of the factors that may have been more relevant in 1965 as opposed to now, 2013? Wonderful. I have a couple minutes. We're going to be taking part, Congresswoman Marsha Blackburn and I are going to be taking part in a committee idea lab, basically just bouncing some ideas and thoughts after this hearing. Some of the proposals outlined by MedPAC will be included in our proposal, and some of the questions we're going to be taking. I look forward to working with this committee and over the next months to explore these ideas and push forward meaningful Medicare reforms that serve the best interests of Medicare seniors. And at this time, I would like to ask unanimous consent to insert to the record this piece of information that we have here, this review of bipartisan support.
Without objection, so ordered.
Thank you, Mr. Chairman, and I yield back the remainder of my time.
Chair thanks the gentlelady. Now recognize the gentlelady from Virgin Islands, Dr. Christensen, for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you, Dr. Hopper, for coming back to the committee. I appreciate MedPAC's recognition of the need for added protections, particularly with regard to the out-of-pocket spending caps in your benefit design proposal, and I think I understand, but don't necessarily agree with some of the ideas behind the proposed reform of supplemental or Medigap coverage, but I'm very concerned with the level of support and protections for low-income seniors, and that analyses done on the impact of seniors as a group may not adequately capture the impact on those that are most vulnerable. Every study that I've reviewed looking at the impact of the cost sharing on patients and patient behavior concludes the same thing, that patients use less services but do not differentiate between necessary and unnecessary, and that those that are poorer and sicker are the most cost sensitive and would be the ones that would reduce the use of services the most. So as you know, the Medicare beneficiaries are poorer and sicker than the population at large. 23 have a cognitive or mental impairment. 40% have 3 or more chronic medical problems. About half of the beneficiaries have annual incomes below 200% of poverty level, and 1/4 have incomes less than $14,000 per year. So these beneficiaries are very much the patient population that is at greatest risk for reducing the use of necessary medical services or deferring important care that results in a preventable hospitalization. And I know you've thought about these issues because your proposal builds in protections for those currently covered by Medicaid. What about the other low-income seniors and the ones with 40%, the 40% with multiple chronic diseases for whom we don't really want to create barriers, additional barriers to care?
Mm-hmm. So, Dr. Christensen, I agree basically with your summary of what the evidence shows about cost sharing. And so I want to emphasize again that our goal is not to increase the average level of cost sharing, but redesign the benefit to make it better for Medicare patients and perhaps reduce the need for them to buy supplemental coverage. We think that using value-based insurance design is very important to get at some of the issues you've identified. We don't want to increase cost sharing on really high-value services, for example, for chronically ill patients. In fact, we may want to reduce cost sharing on those. With regard to the impact on low-income people, we think that there are targeted approaches to dealing with that issue that are better than what we now have. Right now, what we have is a system whereby, in effect, the taxpayers are providing an implicit subsidy for the purchase of supplemental coverage because the taxpayers pick up most of the bill for the added costs. In that subsidy goes to all beneficiaries, rich and poor alike. If the particular concern is low-income beneficiaries, as well it might be, a more targeted way to deal with that issue would be to expand eligibility for the Medicare savings programs. So right now, Medicare beneficiaries that have incomes less than 100% of poverty qualify to get their Part B premiums and cost sharing paid under Medicaid. But above that level, there's no contribution for offsetting cost sharing. Up to 135% of poverty, there are subsidies for the Part B premium, but you still have to pay the cost sharing.
Right.
So if Congress is concerned about low-income people and the impact of this on low-income people, a much more targeted approach would be to change eligibility for the Medicare savings programs. And I would note that the low-income subsidy under Part D has higher income thresholds for eligibility than we have in the Medicare savings programs for Part A and B. So there's already a precedent, if you will, for higher levels of eligibility.
Let me try to get in. Thank you for that. That gives us some idea where to go. You talk a lot about giving the secretary flexibility to set copays for high value versus low value. And I've been following the Patient-Centered Outcome Research Institute that we created in the Affordable Care Act, and I'm wondering, do you see that as being helpful, their work as being helpful to identifying high value, low value in that process?
A number of years ago, before the Patient-Centered Outcome Research Institute was created, we recommended to Congress that such an organization be created and that the federal government support the development of better information for physicians and patients about what works. And so to the extent that PCORI can increase the knowledge base that we have, that's information that could be used in value-based insurance design.
Thank you. Thank you. Thank you, Mr.
Chair, thanks, gentlelady. You recognize the gentlelady from Tennessee, Ms. Blackburn. 5 minutes for questions.
Thank you so much, and we appreciate that you're taking the time to be here. And as Ms. Elmer said, we're going to be spending some time looking at how you do help with the solvency. And I want to ask you just one thing. At my class, when we came into Congress, we were focused on waste, fraud, and abuse. Mm-hmm. We did an entire project, Wasteful Washington Spending. And, of course, Medicare spending continued to come into that picture, and we had example after example of wasteful and fraudulent spending and the abuse of just millions of dollars. So do you think, in your opinion, do you think that the antiquated method, the fee-for-service method, is something that continues to make it possible for this continuation of waste, fraud, and abuse every year and difficulty in running the traps on this and rooting it out?
Yes, we think that waste, fraud, and abuse is a significant problem, particularly in some areas of the program. Earlier we were talking about home health care as an area
Right.
where there's a lot. And where Medicare payments are really generous, and we think they are generous for home health care, that's almost an invitation to people who want to make a quick buck on Medicare. And so
A lot of quick bucks, it seems like.
a lot of
lately.
quick bucks. And durable medical equipment is another area where we think there's been a fair amount of waste, fraud, and abuse, and in part that is triggered by very attractive payment rates that bring in people who are more focused on making money than serving patients.
What would you say is the percent of expenditures that are going out the door, those payments going out the door? What percent do you think are fraudulent payments?
We really haven't looked at that
Okay.
issue. I think the General Accounting Office, or the Government Accounting Office, is Accountability Office. I keep using the old names.
Right,
I've been doing
yeah.
this for a long time. The Government Accountability Office has made estimates. I would
Right,
refer you
they
to-
have. I just didn't know if you
Yeah.
kind of lined up with them or if you had another opinion of that. Let me ask you, looking at that same that same thought and thinking about the solvency and the financing mechanisms. AARP has done reports going back 98, 99, looking at merging A and B and then looking at the financing end of that. Where do you stand with those, knowing that people are concerned? We hear about it every day. Tell me what you know is going to happen with Medicare. Are we really in danger of going bankrupt? And so as you put your reforms forward today, what do you think they will do in helping with the solvency? How long, if we did your reforms, how long would it encourage the solvency of Medicare? How many more years would we get out of this?
Well, that's a question better directed to the Medicare actuaries. What we've outlined is a package that would have a modest net reduction in Medicare spending on the order of about 0.5%. So that's, $2.5 or $3 billion a year, $25 or $30 billion over 10 years. Now, what that assumes is a 20% charge on
Right.
supplemental insurance, in that nobody modifies their decisions. Beneficiaries don't change their decisions about purchasing supplemental insurance. If, in fact, beneficiaries start to say, oh, this new redesigned benefit means I don't have to buy supplemental insurance, or they buy one that doesn't have first dollar coverage, then those savings may increase. And you might go from $2.5 or $3 billion a year to $5 or $6 billion a year.
Well, yes, and that's always kind of the discussion we get into with whether we're using the static or the dynamic scoring and the basis that people make their decisions on. I have one other question, but in the interest of time, Mr. Chairman, I will yield back my time and submit my third question.
Chair, thanks, gentlelady. Now recognize the gentleman from Maryland, Mr. Sarbanes, 5 minutes for questions.
Thank you, Mr. Chairman. Thank you, Mr. Hackworth. Could you just talk a little bit about the relationship between this proposed benefit design change that would impose a higher cost-sharing impact on a patient for a lower value service and a lower cost share for a higher value service? The relationship of that proposal to the change in reimbursement methodology vis-a-vis the providers of care, which is another place where we're looking at this sort of high value, low value dynamic. In other words, you have services now that a primary care physician might be prepared to offer, but there's really no meaningful reimbursement for it, so there's no incentive to do it. So you can envision a situation where there's a service that's not getting covered at all by Medicare. Maybe we want to relook at that, but then at the same time we want to examine then what the cost sharing with Medicare's new obligation would be. And it seems to me those have got to be interrelated to some degree, but we haven't really.
Yeah. So we do think that there are issues on both the patient cost-sharing side and the provider payment side. And I think at the SGR hearing a few weeks ago, the two of us talked about primary care services, which we think are high-value services that often are underpaid under the existing Medicare fee schedule. So in the case of a primary care physician who's taken responsibility for example, under a medical home to manage patients with multiple chronic illnesses, ideally what you might have is lower cost sharing for really high value services for the patient and richer payment for the physician for taking on this very important task of managing complicated patients. Right now, Medicare is falling short on both the provider and the beneficiary side.
In that sense, it's kind of a double investment in redirecting or transitioning the emphasis of where the care happens, and has to be premised on the idea that even that increased investment, which is a combination of higher reimbursement to the physician and lower cost sharing on the part of the patient, that we're going to see it's going to yield savings down the road that justifies both of those investments that we're making.
Ideally, we're working both sides, the provider payment and the beneficiary benefit structure, in doing it in a synchronized way. That's how we get the maximum impact.
Right. Thank you.
Chair, thanks, gentlemen. Now recognize the gentleman from Louisiana, Dr. Cassidy. 5 minutes for questions.
Hey, Ms. Hackbarth. I'll kind of scoot over so we can see each other. I always enjoy your testimony. I always consider it very thoughtful. Now, there does seem to be, though, I always make the point that people in Washington have kind of a centrally planned economy view of how we do things. And if you will, as great as your work is, it truly is trying to anticipate lots of very unique situations coming up for rules that, with that anticipation, work to very unique situations. The very premise seems untenable. Do you see my point?
Well, sort of yes and no. On the one hand, I do believe, and I think we've talked about this in the past, that giving Medicare beneficiaries options, for example, to enroll in a Medicare Advantage plan, a private health plan, is a very important thing to do. And I think you agree with that as well. On the other hand, I must confess, when I hear people criticize Medicare for its administered price system, it sets me a little bit on edge, because I know better than most people the problems with administered prices. I've spent some would say too many hours working on these issues in my career. But when I look at Medicare pricing compared to pricing in the private sector, our system looks pretty good.
No, I'm not, believe me, I'm not defending the private sector.
Okay.
I think that, and I actually like your proposal that if you put these physicians at two-sided risk with some sort of accountability as to outcomes and have the quote-unquote activated patient, that's the better way to go. My concern is that if there's an innovation which is disruptive, it gives you a better outcome at a lower cost, you may not, it'll be 3 years later before that may be priced in accordingly, or even given an ICD and even given a code.
Yeah, and overall, my goal is to decentralize decisions, put as many decisions as possible in the hands of physicians and patients, provided that there's accountability for the results.
I agree. I accept that.
Quality and cost.
Now, the conversation, just to revisit, we probably have had before, the ACO, I think you rightly put the physician-patient relationship at the center of our ability to improve outcomes and control cost. But I see a lot of what we're proposing are actually on the suprastructure, if you will. Here's the patient-physician, but here's the administrative cost, and here's the ACO, and et cetera. And that actually seems to be insulating are denying responsibility for this integral relationship. Any thoughts on that?
Well, so let's use ACOs as a potential framework for decentralizing decisions to physicians and patients. And as you know from prior conversations, I believe in that. Right now we've got an ACO structure, which I think is a step in the right direction, but has some problems with it. And one that I'd highlight in this context is Medicare beneficiaries don't share in any of the savings from an ACO. All of the talk is about how the physicians and the hospitals and the government share in the savings, but there are no rewards for Medicare beneficiaries. We think across the board we need to work on improving provider payment and bringing Medicare beneficiaries appropriately into those discussions and allowing them to share in savings when they go to high-value providers.
And we're totally in agreement on that. I think one thing I would also point out is that if we're going to bring this down to the smaller practice, I'm not quite sure how an ACO would work for a 4-person practice in a rural area, if only because you're only going to get settled up on the positive things you've done 2 years after you've done it.
Yeah.
If you're in a cash flow dependent practice, you probably don't have the wherewithal to wait 2 years to have a settling up.
Although one of the ACO models does involve an advance payment for just that reason to physician-sponsored ACOs. I think it's too early to predict exactly how ACOs will develop, especially in sparsely populated areas like rural areas.
Now,
but about half of the current ACOs involve either critical access hospitals or community health centers and deal with relatively challenging care delivery systems.
I accept that, but we're going so far down the road in terms of planning and implementing political and bureaucratic capital and putting these in place, not knowing where they're going to go and seeing that there's flaws inherent in them makes me troubled. I mean, are the patients, is that unique relationship going to be preserved when, again, we just don't know where it's going?
Well, we certainly believe that preserving that relationship is really important, vital, essential. And I'm maybe a little bit more optimistic than you are that, in fact, the movement is in the right direction.
Okay.
But I think we have to be vigilant about it.
I'm out of time. I yield back. Thank you.
Chair, thanks, gentlemen. And now recognize the gentleman from Florida, Mr. Bilirakis, 5 minutes for questions.
Thank you, Mr. Chairman. Appreciate it very much. Dr. Haber, Mr. Haber, your testimony really touches on the importance of transparency and predictability in pricing and out-of-pocket expenses for seniors in the Medicare program. No other industry I know of would facilitate customers not knowing the cost of service until after it has been performed. Can you explain your thoughts on the importance of out-of-pocket predictability as they relate to the reforms you are presenting here today, or even for future reforms to the program?
Well, Mr. Bilirakis, the most important thing is that we know from focus groups with beneficiaries that they find the current benefit structure confusing and more than a little bit frightening because they don't feel like they can predict what's going to happen, what the bill is going to be if they get sick or even when they go to a physician office, because it's 20, as Dr. Burgess said, it's 20% of what? We don't know. And so what we have advocated is a focus on simplification and protection against overall costs. And we think that that will be very reassuring to Medicare beneficiaries and perhaps over time will influence their decisions about whether they need supplemental insurance and if so, what kind they buy. And that would be a good thing for Medicare.
And you, of course, agree that seniors should be more active participants.
Absolutely.
Thank you. You referenced in your testimony, I think the gentleman from the Virgin Islands referred to this, but your testimony, that's the suggestion that Congress should consider giving the power to the Secretary to reduce cost sharing on services if evidence indicates that doing so would reduce Medicare spending or lead to better health care outcomes and vice versa. Can you elaborate on that?
Well, I'm not sure I have a whole lot new to say on that, but we do think that services are of different value to patients. Certainly, we know that some services are really important for beneficiaries with chronic illness, and we don't want cost sharing at the point of service to be a barrier to that care because the patients will be worse off, they'll have worse health outcomes, and Medicare will incur higher long-run costs. And so as opposed to a crude approach to cost sharing, which just says same rate for everything, 20% across the board, we think we can do better than that, be smarter about it, and have better results for patients.
Thank you very much. I yield back, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentleman from New Jersey, Mr. Lance, 5 minutes for questions.
Thank you, Mr. Chairman. I'd be happy to yield my time to Dr. Burgess.
I thank the gentleman for yielding. Mr. Hackbarth, just a couple of follow-up things. And thank you for mentioning HCFA. Brought back memories of when I thought HCFA was a 4-letter word when I was in practice. Back in the 90s, with the passage of the Kennedy-Castlebaum bill, that behemoth that gave us HIPAA, but it also allowed for the first time the sale in this country of medical savings accounts. But if I recall correctly, they were very careful to keep that type of insurance out of the Medicare system. Is that correct?
Yes, I think that's good.
Well, I guess here's my question, and I still have a problem with the concept that, and let me be very honest with you here, I've got someone in my household who's going to turn 65 this year, and we are just deluged with stuff from people wanting to sell a supplemental policy. So I can certainly sympathize with the person who looks at all of this information and, oh my gosh, I want to do the right thing. I want to be prepared for bad things that could happen. So I will make this investment. It's hard for me to believe that that's an erroneous activity for that person, for them to be engaged in that. You kind of indicated in your testimony that a lot of times what they're paying in for that supplemental is far in excess of anything they would get from a benefit from the supplemental payment. Why don't we make it easy for people to put additional dollars away for their health care in a Medicare health savings account that would be available to them to draw on and need if there were costs over and above what the Medicare benefit would provide them?
Dr. Burgess, we haven't looked specifically at the issue of medical savings accounts for Medicare beneficiaries. So, I don't have a MedPAC view on that.
Let me just offer you an observation. We talk about 10,000, 12,000 people a day entering Medicare. There are going to be more and more people who enter Medicare with a health savings account that actually has cash in it that was not used prior to the time of entering into Medicare. Are you looking over the horizon at all and trying to figure out how do you deal with Bill Cassidy called them the activated patient? That's exactly right. Governor Mitch Daniels, when he provided his Healthy Indiana program to state employees, which essentially was a high-deductible health plan coupled with a health savings account, he made the observation that something magic happens when people spend their own money for health care, even if it wasn't their own money in the first place. But you've got these people arriving into Medicare, aging into the Medicare system with a large health savings account that they're holding. Why not allow them to participate in their care?
Well, this is an issue of personal interest since I'm going to be 62, and actually my wife and I have a health savings account. We've been insured under a high deductible plan for quite some time now. So it's an important issue. It's not one that we've looked at this point.
Let me just make another observation. I mean, I know fee-for-service gets a bad name and a bad rap in a lot of ways. Dr. Cassidy referenced to the small practice in a rural setting. I always allude to the solo practitioner in Muleshoe, Texas, who really can't participate in an ACO. Yes, they can be acquired by a network, but You know, every time I think of accountable care organization, I have to ask myself, accountable to whom? Because as Dr. Cassidy correctly pointed out, there are significant, because of the risk factor, there's a significant cash amount that needs to be available that is generally not available to the small and individual practice, so that there is someone else who is going to have to be, if you will, a financial or fiscal partner in that endeavor. So it just begs the question, accountable to whom? Is it accountable to the hospital? If the doctor is accountable to an accountable care organization, is that really accountable to the hospital or to the government or to a health plan? It kind of begs the question, are they still accountable to the patient? And just speaking from a professional standpoint, I am worried about the direction in which that is going.
Yeah. Well, there are, to be sure, lots of complicated issues that need to be examined and resolved around the development of ACOs. I think it's a step in the proper direction, and I say that because I really am looking for structures that decentralize decisions so that clinicians and patients can make them together, subject to accountability on quality and cost. Now, exactly how you set the cost and all the issues about the flow of the money, those are really important things. I don't mean to diminish their importance. But if the goal is getting the federal government out of intrusion into medical practice, structures like this, I think, need to be part of the solution. So let's focus on making them better as opposed to undermining them.
Thank you, Mr. Chairman. I'll yield back and thank the gentleman from New Jersey for yielding the time.
Chair, thanks, gentlemen. We have a unanimous consent request.
Mr. Chairman, I ask unanimous consent to submit for the record various statements from the United Steelworkers, California Health Advocates, testimony on behalf of the International of the UAW, a statement from the National Association of Home Care and Hospice, and a statement from the National Committee to Preserve Social Security and Medicare. And I believe you have all these.
Yes, without objection, so ordered. That concludes a round of questioning. We have some members who have additional questions. I remind members they have 10 business days to submit any additional questions for the record, and I ask the witness to please respond to the questions promptly. Thank you very much for your time, your testimony this morning. and members should submit their questions by the close of business on Thursday, April 25th. Thank you, and without objection, the subcommittee is adjourned.